Okay, it's 2 minutes after, so we will get started. Good morning and good afternoon, ladies and gentlemen. This is Mark Arnold, Executive Vice President of Marketing with ZAP Surgical. Thank you for joining us today for the webinar, The Future of Radiosurgery Starts Here, Built on Experience, Focused on Tomorrow. Before we get started, all participants have been muted, but we do encourage any and all questions be submitted using the Zoom Q&A button at the bottom of your screen. And at the end of today's talk, we will do our best to field all of your questions. However, if we are unable to answer all of them, we will follow up with you individually. So with that, I would like to introduce today's first speaker, Dr. John Adler, Emeritus Dorothy and T.K. Chan Professor of Neurosurgery and Radiation Oncology at Stanford University, and former neurosurgical fellow of Professor Lars Leksell at the Karolinska Institute in Stockholm, Sweden. And there's even more. He's the inventor of the CyberKnife and original founder of Accuray. And last but not least, the inventor of the ZAP-X gyroscopic radiosurgery platform and CEO of ZAP Surgical. So, Dr. John Adler, over to you.
Thank you, Mark, and I want to welcome all the attendees at this webinar. It's a privilege to be able to tell you more about where ZAP is headed and where we aspire to be. First, I'd like to give a shout out to my mentor, Lars Leksell, as Mark so admirably just indicated. Professor Leksell and his Gamma knife really rocked my world as a resident and as a fellow for Leksell a generation ago. And if you look on this slide here, the image, there's a guy with some little bit of red hair in his head. That was me before I wasn't so follically challenged. So when I went to Stockholm, I thought I knew something. I was a Harvard man. But when I went and saw what was happening at the Karolinska in the world of radiosurgery, it transformed my life, and I've never looked backwards. And I'm forever grateful to what Leksell did for me, and I think for the world, developing a whole new concept in non-invasive surgery that has transformed, I think, the world of neurosurgery to date. So as much as I respect what Leksell did, I also know that Leksell was never one to sit still in his laurels and was kind of a restlessly always looking to do better. And so trying to follow in those footsteps, I have sought to make a next generation radiosurgical product than the ZAP-X. Now, as good as the Gamma knife is, and I think it's a wonderful, marvelous technology, the ZAP-X tries to equal it in all of its abilities to treat patients with quality, yet at the same time, do many other things, both in terms of eradicating, getting rid of radioactive cobalt, getting obviating the need for radiotherapy bunkers. And that's in fact what we've accomplished today, and that's what we hope to tell you a bit more about. In the end, we hope to expand the visibility of radiosurgery, make it more available, and treat what we believe is 5 million patients each year who are not being treated with optimal types of treatments. So kind of the purpose of this call today is that many of you may have a Gamma knife or not, but when you do have a Gamma knife, you have a inflection point at 5-6 years. What do you do as the cobalt decays? Do you go and recharge your cobalt, or is it time to start thinking about something new? And so that's hoping the discussion we'd like to start today in this webinar. There's some good reasons to want to work with radioactive cobalt, especially in the insecure world we have today. And cobalt is kind of scarce and nasty stuff to make, in Africa and then charge in radioactive nuclear reactors. Moreover, the radioactive decay of cobalt-60 changes the length of treatment time, changes the BED. And so there's no two Gamma knife treatments are ever identical because the cobalt has changed output and changes BED in effect. So today we're going to talk to some peers, some colleagues who have navigated this decision in the past and moved from Gamma knives to now to ZAP-X. We're going to help them to tell their story, and you'll have a chance to ask some questions. And hope that you will appreciate that the ZAP-X is an evolving platform, hopefully here created to serve your needs, and hopefully, as you'll see, getting ever better as we go forward into the future. So I'm going to introduce each one briefly before they give a talk, but these are the three speakers besides myself who will be speaking, and the order in which they speak: Dr. Danish, Tim Chen, and then finally we have Hemmings Wu, who's also Chief Medical Officer at ZAP. Now, you will be hearing from Hemmings about some futuristic concepts in radiomodulation. Understand these are still works in concept, they're not FDA regulated, and Mark wants, or not FDA cleared. Mark wants me to make sure I emphasize that to all of you. But as a scientist, a neuroscientist, I believe in the near future, they will become a regular part of our life. Well, to start with, let me introduce you Dr. Shaber Danish. Dr. Shaber Danish is currently the director of neurosurgery at, Jersey Shore Hospital in the Hackensack system in New Jersey. But more importantly, Shaber has worked throughout the Philadelphia, Jersey corridor at multiple academic institutions, working with gamma knives, Insight Tech, all kinds of cool technologies, working with the synaptive MRI scan, has some interesting thoughts on how imaging can be more readily connected to radiosurgery. But anyway, he's going to lead off our neurosurgical discussion about how he, as a neurosurgeon, thought about the transition from gamma knife to ZAP-X. Off to Shaber.
Shaber, you may be muted.
Okay. Can you see my screen?
You look good.
Yes.
We can hear
Yes.
you.
Hold on here. Okay. Are we good here?
We're good.
Okay.
Take it away, Shaber.
All right. Dr. Adler, thank you very much for the introduction. Thank you, everybody, for joining. I'm going to take a few minutes to go through my own path. And just to introduce the concept to you, I came to a facility that actually did not have a dedicated cranial radiosurgery platform, and really pushed hard for me to, purchase a gamma knife. And prior to coming here, I had, built the gamma knife suite at my prior institution, brought it, there from scratch and really built into a very busy program. So it was a little bit of a leap of faith for me, and I'm going to take you a little bit through my own thought process here because this really was, questions. Why do we really need another SRS platform? We had only one, which was a gamma knife, which seemed to work well. At that time, I had a couple of issues that we thought about. Patients really didn't love the frame, issues with cobalt dose rate and the source, and then the cost. Of course, once the construction is done, it's not really an issue, but it's really when you're thinking about, putting something new in. And then we had issues with non-cranial platforms. Why did we choose to use a machine like the gamma knife to begin with? It's because we believed that, the dose gradient mattered. We believed that the accuracy of the target and the dose of the target versus sounding structure mattered. And we, at some level, believed that, the extracranial radiation exposure, made a difference, especially in treating benign pathologies. Now, uh, over years of data collection across different pathologies, we have come to understand that dose rate does affect treatment efficacy in many of the things that we treat. Trigeminal neuralgia, control rate for meningiomas is affected by your dose rate, and the BED changes for functional procedures as years go on. And probably the time which this really starts to matter is probably coming close to about 3 years from when you installed a cobalt. And as you know, nobody really replaces their cobalt every 3 years. Institutions keep pushing harder and harder, and I've seen institutions take the cobalt, to 6 or 7 years when they can, just because of the expense and the demand, required to actually change, the cobalt. And then the extracranial dose is, much higher. We know this from even as gamma knife programs were propagating, but the extracranial dose, from traditional Linux is much higher. And you can see at least here that, much lower for gamma knife, and then ZAP-X comes pretty close. So when we come back to this, we talk about the frame. Now, Gamma Knife did solve this and it did put an onboard, CT scanner, and does now offer mask-based a solution. And the question is, well, how long can a patient really sit in a mask? And this is where when we embarked on this, started to see some issues. Now you see here that, as the cobalt ages, the treatment time changes. And for any of us who did trigeminal neuralgia cases, doing it with 5-year-old cobalt became very challenging. the treatment time doubled, whereas on Linac it stays consistent. And what we found is that, patients can tolerate probably being in a mask for 45 minutes to an hour, but as the treatments get longer than that, they just can't sit in the mask. You have to take breaks, and those treatment interruptions make the total treatment time much longer. And then comes this last issue of, how long is, we're going to be able to find cobalt. It becomes more scarce, and it is going to enter into the critical supply risk, quadrant here shortly. So, from that comes this idea of the ZAP-X gyroscopic cranial radiosurgery platform. It's a self-shielded machine dedicated to brain and upper cervical spine that, is built as a LINAC without, the need for cobalt. With the fact that this is self-shielded has made a huge difference for us when we thought about building from scratch here. 10 years ago, it took me about $8 million to build a Gamma Knife, vault from scratch, and we did it in less than half, by putting in a ZAP-X. And as I'll show you at the end here, we also have it in a room that's just surrounded by windows. And this is a picture of ours and some other suites that are built in a similar fashion. So as Dr. Adler alluded to in the beginning, you don't have the recurring cost of the cobalt. The rules for how the treatments can be managed or changed, and they are in line with other LINACs. You don't have the security overhead, and of course, you don't have the issues with inconsistent dose rates. As a dedicated radiosurgery platform, this checks a lot of the boxes off. You have beams coming from all directions, and much more options even when compared to the Gamma Knife and the CyberKnife. You have low scatter, you have a sharp penumbra, and you have low collimation leakage. And these are all things that we were yearning for, when we looked at other LINACs prior to this coming on, online. And here you have a schematic representation of the beam availability between the different platforms. And you can see, with ZAP-X, you get a lot more options here. And this allows it to, be much more nimble in dose delivery and in tightening, the dose to the surrounding structures. Leakage rate is low, which is what we're looking for in these machines. And the penumbra is also low, and it comes very close, if not rivaling the Gamma Knife, as a linear accelerator. The beam scatter is also low. The beam profiles across all axes look great, and what you'll see here is the ZAP-X provides a tight profile in all three directions, or all three coordinates of delivery. And you see the dose distribution on the standard LINAC versus the ZAP-X. It starts to mimic what we're used to seeing as Gamma Knife users, where you see a lot of dose to the target, and a small and much lower volume of dose scatter in the normal brain. We're ultimately trying to achieve low volume of brain affected by dose and scatter, and also high low treatment times. So we're not there yet, with ZAP-X. It is, but as you'll see, perhaps at the end here, with advances coming for ZAP-X, we should be able to achieve it. The total brain dose comparison is favorable. It rivals Gamma Knife, and the metrics are much better across the other linear accelerator platforms that have traditionally been used to treat disease in the brain. Now, you have 9 apertures for beam collimation, and so you can get as low as a 3 millimeter. And I'd say that for those folks treating trigeminal neuralgia, this does make a big difference. I'll go into. I think Dr. Chen will go into this, in his talk. But we found it to be advantageous. But this gives you a lot of options in terms of creating dose plans in order to treat these disease processes. You can see here the difference that a smaller collimator makes in treating the trigeminal nerve. The machine itself has safety features along every step of the way here. So here you have integrated KV imaging that allows you to register the skull once the patient is settled into the machine. And this serves as a checks and balances before the procedure even starts. And then throughout the procedure, you have several safety checks here. Let's see here. So this is the machine will calculate expected exit dose, and as the treatments are ongoing, if there's any deviation, it'll stop, which allows you to go back and check for errors. But this is a safety feature that I think has made us very confident that the treatments are occurring the way that they need to. Let me go over a little bit of the machine architecture. This is the machine is self-shielded. As you know, it runs on two different axes, which gives it the beam availability from all angles. Um, you uh, the machine itself is completely, self-shielded. There'll be a line that gets drawn around the machine, which is fairly close, and we are inside the machine, the vault, as the treatments are ongoing, which has made a big difference in terms of the construction costs and the ability to, actually be in the vault while the patients are being treated. Here you see where some of the important structures are located inside the machine, including the collimator wheel, the imaging detector, and the actual linac itself. It is, even though it's a closed machine, it is a wide space. And you can see here it's, the comparison between a CT or an MR or some of the other machines. And so although it's closed, it should, feel much less claustrophobic than sitting inside the other machines. Let's talk, we're going to take a few minutes to talk about clinical workflow for anybody doing, these procedures. You can understand that there are a lot of steps along the way that we have to ensure to provide us, an accurate treatment. It starts with good imaging, and then, fusion, target localization, and then everything else that's involved until we can be assured that the shot is going where we want it to go and where we think it's going. So here, in terms of linac workflow, this is a little bit different, from Gamma Knife. You are going to require a CT scan. You do have to, create a thermoplastic mask. The CT and the MR that you're going to use for planning is then transferred onto a software platform that you'll decide. Today, we are using a third-party platform, and at our institution, we're using Eclipse. And I imagine this is different in different places. And as the ZAP-X TPS changes, this will probably all migrate onto the ZAP-X treatment platform as we move forward. For those folks who want to use a frame, there is a immobilization solution for ZAP-X. At our own institution, we have not used this. We have been very satisfied with the accuracy we deliver in a mask, even in treating trigeminal neuralgia, and have not seen any issues to date. Once the imaging is acquired and we've developed the plan, which is on a third party, or developed the contour, on a third party software system, we then are moving it back to the ZAP-X treatment planning system in order to complete the plan and then send it to the machine for QA. Today we are, as I mentioned, we are using Eclipse. So these are just some of the steps involved. Along the way, we have seen automated isocenter placement on the ZAP-X treatment platform, which has remarkably reduced the time period that we need to place our shots, manually. And because of the interest of time, I can't go into the details of validation and what we've seen in terms of automated versus manual isocenter placement. But as a one-liner, I'll let everybody know that from our perspective, it rivals manual placement in terms of its ability to provide the metrics that we're looking for. So I think at its onset, it performs extremely well. Once these plans are done and we're set for delivery, as we discussed, patients get fixed to the machine in a thermoplastic mask or the pin immobilizer. You'll go through KV imaging as a part of the checks and balances before the treatment is initiated. All these beams are tracked, as I mentioned earlier, and this is a little bit about what what the control system looks like as it's moving from shot to shot. You'll get this little graphic as it's moving along its plan. And you'll see all the metrics on this control panel, which usually sits less than 3 or 4 feet from the machine itself.
Schaber, you have 2 minutes.
This is what the treatment summary looks like. And I'll tell you in these last 2 minutes at our facility, one of the issues and hurdles we had was actually getting insurance approvals for the imaging. So at our, we'd get these imaging and then want to treat the patients. They'd go back for, planning imaging, but we'd get caught up in this vicious cycle of denials and approvals as the radiology group, even though it was our own, required us to get insurance auth for the planning imaging for Gamma Knife. And it's really started to create a lot of delays here. And, this is I don't know if this is a phenomenon everywhere in the country or in the world, but definitely is an issue on the East Coast here. So when I got to the new facility, I was able to convince the board to put in a dedicated head-only MR that we control that actually does not require an MRI tech. It's completely automated. It's run by our physicist and/or our radiation nurse, and does not require a level 2 certified MRI tech, which is a major advantage in putting this machine in. It gives us complete control over image acquisition. If we're not happy with the images, we just hit the button again and acquire them. And what used to take us an hour to acquire in terms of imaging for Gamma Knife, we can now do in about 20 minutes. I'll spare us all of this, but I'll tell you that there's no way that anybody could tell the difference between the images on this machine and a 3 Tesla machine and a 3 Tesla image, especially for the purposes of radiosurgical planning. So we were able to eliminate, this hurdle for us. These are some pictures from our own facility here. We were early adopters in terms of implantation of ZAP-X. We are hundreds of cases in, and have been, extremely satisfied with the input and the attention, from ZAP-X as a partner in order to make sure that we are delivering what we need to the patients and for the program. This is a picture from our facility. It shows the machine sitting in glass, room where thousands of patients are walking by. It's fantastic. And with that, I'll stop there. All right, John, Mark, I think I stopped right on time.
Perfect. Thank you. John, over to you.
Thank you, Shopper. And always important to hear a neurosurgical perspective. Now we're going to hear a radiation oncology perspective, also from Hackensack, Jersey Shore. Doctor and Professor Timothy Chen is the chairman of radiation oncology at Jersey Shore, and has considerable experience working with all major radiation modalities, from gamma knife to protons to cyber knives, my old child. But we're going to hear a little bit about what he thinks about the ZAP-X and why it made sense rather than going with the gamma knife solution that many people were expecting him to do at Jersey Shore. So, Dr. Chen, take it away, please.
Thank you, John. Thank you, Dr. Danish, for the kind words and introduction. So I'm Timothy Chen, and I'm working at Jersey Shore, and also part of the John Thawer Cancer Center, part of the Hackensack Meridian Health. So it is an honor and pleasure to share our experience, and let me tell you, it is exciting. So we are an 18 hospital system. So we have 3 academic centers, we had teaching hospital, we're a medical school. So when I first walk in, and at that time, this system already had 2 gamma knife, had 1 cyber knife, had proton therapy and reflection, all kind of Linux that you name it, we have it. So we love toys as a radiation oncologist. But rolling forward, about 3 years after we have ZAP-X, both our gamma knife, it's being decommissioned and be replaced with ZAP-X. So I'm very excited to tell you we're gonna have 3 ZAP-X in our system. So when we looking at the platform of Stereotactic radiosurgery, as you can see, you probably well known, they are cyber knife, they are LINAC, they are gamma knife. So we are looking for something like give us the freedom as a radiation oncologist. We like to beam to come in all direction, give us a freedom. So the first thing I pay attention, I got this is this ZAP-X machine offer 2 pi of the freedom of the angle, and the ultimate rule is try to achieve this picture, the stereotactic, just the tumor, not to touch anything in between the tumor, which is the normal brain. So just like Shopper said, we had this pair of ZAP-X with synaptic MRI, which is a really, really good, help us a lot of scheduling issues. So with that, we consistently achieve the alignment precision. So far we collect more than 16,000 alignment data already. So our average discrepancy is 0.3 to 0.5 millimeters. And the planning system, just like Gamma Knife, drop shots. For those people who use Gamma Knife, you're gonna come and say, wow, that's what I used to do. So I have some case like to share with everybody. So pick the first one, the radio-resistant tumor. So this is a 77 years old female who had metastatic malignant melanoma. She presented with 4 lesions, very symptomatic. The biggest one is 14 cc. The smallest one is 0.6 cc. So these are her 2 infratentorial. As you can see, there are 2 supratentorial lesion. Usually when we see this kind of thing, we like to have a surgery. Unfortunately, she is not fit for surgery because of cardiac and pulmonary function. So we have to do SRS. So with this very large tumor, 2 infratentorial and 2 supratentorial. So we able to come up with one plan, treated them, and guess what? 2 weeks later, as you can see here, left and right, 2 months after, we don't see the tumor on the repeat MRI. So we were very excited when we first saw this. So we further adventure on, okay, why don't we pick a very large and irregular target? And this is coming to play. This lady had recurrent cellular meningioma, was previously treated with Gamma Knife. And this tumor is not just big, 37 cc. It's so irregular. It covered both cavernous sinus to brainstem to everything that you can end up, as you can see here. So we went ahead, did a comparison study. So at that time, we just have a ZAP-X before the upgrade and after upgrade. So by the time the upgrade, they add posterior beam. So the upper left corner, this very much represent the CyberKnife treatment planning. On the right upper corner, this is the new ZAP-X, which is a whole spectrum of beam. And the lower one is the Edge, which is a LINAC SRS platform. So these are the comparison. As you can see, across the board, the ZAP-X give you the best, the OAR sparing. The brainstem, optic nerve, optic chiasm, the CI/GI, both are very, very good. Now, okay, how about let's look at small target. So we had this optic nerve sheath meningioma, 68 years old female, present with proptosis, retroorbital pressure and pain, and vision loss, which is she can see the black and the dark and bright, can recognize some imaging movements, so had little minimal residual vision. We plan with the radiation for this optic nerve sheath tumor. So we did 5x5 prescribed to 61%. And her tumor, we did a case report 4 months later, they about 40% tumor shrinkage. Up to today is more than 1 year. She still have a residual vision without change. Since the first day, her ptosis, her pressure has resolved. Now, large AVM. This is a frequent, especially for neurosurgeon, also some specialized radiation oncologists deal with this large AVM. So this patient, 34 years old, without symptoms. This is just incidental finding, but this target is very big. It's about 10 cc. So we did a CT diagnostic angiogram to identify the feeding vessel. We fused with MRI and MRA, and we did SRS treatment planning with ZAP-X. So as you can see, we also use tractography to help us to avoid any visual disturbance issue in the future. So we did 9x3 because the tumor, this target is quite large. We had to fractionate it. The treatment itself 39 minutes for 3 fraction. And this is the before and after. As you can see, his AVM start dissipating. Now, how far low can we treat the spine tumor? Yes, we can. Obviously, depends on the patient's build. very long, skinny, tall versus short and stocky. So in average, we can treat to C4, C5 should be okay. And this is the case present with C2, C3 spinal schwannoma. As you can see, this tumor is literally touching the spinal cord. So we routinely compare the ZAP-X treatment planning with our edge treatment planning. So we found something amazing. As you can see, those are yellow line, those are the spinal cord dose, which is almost identical to the edge treatment planning. But it's not just stopping with that. As you can see, this is shady area. Those are that much extra dose ZAP-X able to provide to the target without sacrifice any OAR. I'm not saying every routine case we should dose escalate, but point of view is that if there are dose escalation required, this is a radio-resistant tumor for anything, these are the extra dose that you can comfortably provide with ZAP-X treatment planning system when compared to the conventional edge SRS. So side effect, very, very mild. They usually a little tired for a couple of days after, maybe a little headache. Tylenol Motrin will take care of it. Hair loss is very rare. We only see them if the tumor is very close to the scalp. We routinely use VTRL to identify, to help us for the treatment planning. So it helps us to predict the complication rate, which is radiation necrosis. So 5 cc, 10 cc, more than 15 cc. It helps us to compare treatment planning. We want the best of the best for the patient. It also helps us for the future to identify the pseudo progression versus true progression because we'll look at these doses as well. When we treating the multiple brain mets, so this may not be so useful, but we still use them because it gives us very tight guideline. So it helps us knowing that total tumor volume, it almost got a red flag. Watch out for this because of radiation necrosis. It helps us different treatment planning. So this is time we can be very creative. We can dose painting, we can target grouping, we can do spatial temporal fraction. So all this help us. Very, very happy to tell you our brain necrosis rate less than 3% throughout all our treated patients. So these are the two cases recently, 61 years old, present with a metastatic gastric adenocarcinoma, 10 target, quite large. So we did 8 times 3, prescribed 58%. Treatment time was 53 minutes. So she tolerated quite well. And her GTV V12 is 15 cc. These are the case. People ask how many lesions can you treat? So put a big disclaimer, I am not routinely treating 38 mets, but this is a unique case. This 73 years old gentleman present with metastatic renal cell CA. He is veteran. He has BKA, both knee amputated. He is diabetic, heart disease, but he lives alone. The only thing work of his body is the brain. So he crying for, I need to keep my cognitive function. So throughout the year and a half, we treat him 3 times. Altogether, there are 11 ZAP-X treatment. We treat total of 38 mets. So up to today, he is about 12 months after the first treatment, about 15 months after the last treatment. He is cognitive sound. There is no debilitating. He still lives alone. And yes, we haven't seen brain necrosis either, which is very unique. So how we know this is a good platform to pick, and thanks to this recent publication from Curious, from Stanford, from Miami, this one picture tells all. So pretty much it compare the platform between TrueBeam Edge with multiple isocenters, CyberKnife, Gamma Knife, and ZAP-X. So these are the 10 lesion platform treatment planning. As you can see on the TrueBeam, they purposely pick these 2 lesions side by side, want to see how good you can distinctively irradiate them without touch the brain. So the true beam, you see a lot of 5 gray dose spread out a lot of brain. And you can see on the edge, single isocenter, a lot of 5 gray spread it out on the light blue. And if you see with 3 isocenter, obviously with 3 isocenter edge, it takes a longer time to treat. You have to kick the couch, you do a combine CT. Now we have a cyber knife. Now we have gamma knife spirit, gamma knife icon, and here we go. This is the ZAP-X treatment planning. As you can see, we only give tumor the dose. The rest of the brain has been spared. So that is the true future of the SRS. You only treat the tumor, not touch anything else. So we touched on about this, the V12, V5. So the ZAP-X currently have a lowest whole brain dose, similar to the gamma knife. Actually, it talk about 2 hours. We do not treat any case more than 60 minutes. So everything of our treatment planning has been lowered down to less than 1 hour. So this one last case. Thank you. So this patient have a 6 meds plus craniotomy. So present difficulty is that she had a craniotomy for, as you can see, left cerebellum right here, but also symptomatic from the others. So we really able to treat her about 1 week after craniotomy because we can spare the tissue in between, as you can see here. And these are the comparison. The V12 is significantly lower than the edge comparison plan. So our current experience for the last 200 patients, we published this in Curious. So our brain mets control 97% in 12 months, 89% in 16 months, way beyond the benchmark of 80% in the other studies. CI and GI average is all coming very nicely. And the treatment time. So study showing that if we treat a patient more than 13 days after the diagnosis, the control rate is not as good. We have this patented 3 days regimen. So from consultation to treat them, we can do that in 3 days comfortably. Also with this, because of the treatment planning time and the treatment time is different, so the physician, radiation oncologist, neurosurgeon free up a lot of time without being tied in as like a gamma knife. We do everything in the same day. So with that, we can easily treat 6 patients a day without a problem. Meanwhile, I can still do the consultation and other daily routine. So these are the patient flow. Patient comfort is the most important things. And so I strongly urge people, this is my slogan now, when acceptable is no longer acceptable. If you can treat something like this left side, why you do the right side? That's a lot of normal brain tissue got irradiated because of a lot of brain mets, they do show up a second time, a third time, because of systemic control, it's pretty good. Do not burn your bridge, which patient will thank you. We're treating a lot of benign condition as well and exploring the essential tremor, addiction, refractory, depression, OCD, obesity. It's all in the horizon. And we treated all this condition. And the learning curve is pretty good. Maybe from beginning, for most people, this is a brand new platform. So we worry about it, but rest assured, the learning curve is pretty easy, adaptable. So the last slide, this is unexpected halo effect we know and learn from the ZAP-X. First of all, it promotes a working relationship between radiation oncologist, neurosurgeon, neuro-oncologist, and medical oncologist. In the past, linear user, we do radiation SRS ourselves, cyberknife the same thing, gamma knife mostly neurosurgeon driven. So ZAP-X is the first platform put all us working together. With this, patient doing better, patient live longer, the usage of ancillary service starts showing increasing the radiology, the lab, the pathology, everything. It promotes hospital regulation because the patient tells us now. They tell people, their friends and family, listen, I got ZAP-X, see how good I look, and patient treated the other platform. So it makes the SRS program is more accessible, more modern, and visually compelling by looking at the picture. It increases the throughput because now we don't have to tighten the neurosurgeon radiation oncologist time or for radiation oncology, we just need to check the start and I can continue my daily routine without interruption. So with that, we also know brain mets patient a little longer
Okay,
now, so easier to plan for second and third fraction. So one last, an
very good.
ideal exercise platform, it's important for we plan for benign disease, the future functional radiosurgery. So that's
Excellent.
all for my talk. Thank you.
Thank you, Dr. Chen. Great experience to describe to the world, and I know that Jersey Shore is doing a lot of special things. So congratulations and thanks for your presentation.
Thank you.
Lastly, the last speaker is Dr. Hemmings Wu, Chief Medical Officer of ZAP. Hemmings is a very experienced functional neurosurgeon, having trained in China under Bowman's son, one of the legendary functional neurosurgeons, and trained in Belgium and at Stanford, where I got to know him with Casey Halperin. Very few people in the world know more about the full gamut of neuromodulatory opportunities today in the world. And I'm excited to have him talk today about radiomodulation with the ZAP-X. But one more time, this is all a non-cleared FDA procedure. So be forewarned, we're talking about the future, not the present. Take it away, Hemmings.
Thank you. Thank you, John, and thank you, Tim and Sharber, for the beautiful presentation. My name is Hemmings Wu. I'm the Chief Medical Officer of ZAP-X, ZAP Surgical, and today I will be sharing some of the insights on the future of SRS, which is neuromodulation with the ZAP-X system. And again, radiomodulation or radio neuromodulation is not FDA cleared. In the very beginning, when we first discovered radiation, we somehow know that it's very good at killing things. So when first applied in medicine, that's how we use it. We use radiation to kill tumor cells, to kill the bad cells in our body. And it's been working pretty fine the last more than 100 years. Here at ZAP Surgical, we spent more than a decade, last 10 years or so, with a tremendous amount of resources and time into perfecting of using radiation to treat brain tumors. And we've reached several important milestones. For example, last year we treated the 5,000 patient at Hackensack, Jersey Shore. And I think earlier this year we treated patient number 6,000. And there are many publications with large numbers of patients being treated with our system. And I'm very proud of what we achieved so far, but we're not going to stop here. This is the current neuromodulation modalities, so including using electricity, for example, DBS, deep brain stimulation with magnetic, for example, transcranial magnetic stimulation, and with sound, for example, focused ultrasound. They all work in a different way, but each of them has limitations. For example, DBS requires implants, which is very invasive technique for patients. And for example, TMS, we can only modulate the superficial cortical regions. And for focused ultrasound, the energy barrier, the skull mainly, is always the big issue here. At least here in Asia, what we heard is that we've seen in reports that more than 50% of patients are not ideal due to skull density, are not ideal patients for focused ultrasound. Now, what if I tell you that radiation is another form that we can use to modulate neurons? Of course, again, radiomodulation is not FDA cleared, but this is not some science make-believe that we just created. Of course, this is a video we created using artificial intelligence, but there are many, many evidence indicating that radiation does more than just killing cells. For example, in this Nature Reviews Immunology paper, shows that radiotherapy modulate immune system. And in our collaboration with labs around the world, for example, this one is with laboratory in Germany, where we showed that radiation can actually, low dose radiation, by the way, as low as 5 gray, can actually change neuronal activities. So this is done in a rodent model. And what we see here is that by applying low dose radiation, for example, 5 gray, 20 gray, or 40 gray, we're able to elicit neuronal firings recorded in an animal model. But of course, this is done in a normal animal model, mouse model. What happens when you apply it to a disease model? So this is what happened. When we try to use the same low-dose radiation in the nucleus accumbens in a pig model of alcohol addiction, we're able to actually reverse the drinking behavior seen in this animal models, as you can see here. And these figures, for example, in the top right-hand side, the bar graph, you can see clearly that we're able to reduce the drinking behavior in these very severely alcohol-addicted pig models. And more importantly, this is not done through making a lesion in the accumbens. You can see that in this brain slice in the pig model that we don't see any sign of lesioning in the accumbens in the target area. So what we see here is a very unique window, somewhere between 5 gray and 40 gray, that we're actually able to modulate neuronal activities with low-dose radiation without making a lesion. And this definitely opens a whole new avenue of treating many different neuropsychiatric disorders using radiation. We're talking about addiction, obesity, chronic pain, depression, PTSD, anxiety, OCD, list goes on. So as of today, there are already 4 patients treated with radiomodulation in Beijing. This is in collaboration with a center in Beijing, 301 Hospital, which has ZAP-X installed there. And you can go on clinicaltrials.gov and find out all the details of the trial design there. But first 2 patients were treated more than 4 weeks ago, and second patient number 3 and 4 were treated 2 weeks ago, a little less than 2 weeks ago. And so far, no adverse events has been reported, and we're seeing moderate changes, improvement in a scale in one of the 2 patients treated in the beginning. And of course, I want to remind you that this is very preliminary results. We're still in the trial period, and again, radiomodulation is not FDA cleared, but we're very excited of what's happening for this treatment-resistant depression. Our target is SCG, or subgenuine cingulate gyrus. It's a classic target with DBS, and on the figure on the right, you can see that this is where the hotspot or the sweet spot is based on the previous DBS clinical trials. I have to say, I'm a DBS neurosurgeon too. I've been doing DBS my whole life. I'm a functional neurosurgeon. And although as much as I love DBS, I've been involved in many DBS for depression trials too in the past. For example, it took me more than almost a year to recruit just 2 patients with DBS for depression. And for this radiomodulation concept with a non-invasive, no implant required, the recruitment speed is just much faster. For example, for this trial, which was just published on clinicaltrials.gov at the end of the year last year, they're very close to completing the interim analysis of treating 9 patients. The goal is to treat that in the next month or so. And besides depression, we have radiomodulation for loss of control eating as well. So on the left-hand side, we have the focused ultrasound. This is a study done with alcohol use disorder in Taiwan, which this is a Taiwan Shotron hospital. They have used non-ablative, subablative thermal stimulation with focused ultrasound in the accumbens in hopes of controlling alcohol addiction. And at the same center, they are, as we speak, installing a new ZAP-X. So they're interested in loss of control eating, and they are thinking using low dose radiation for the treatment of loss of control eating as well. And on the right-hand side, you can see that some past studies with gamma knife, but this is again lesioning procedures. So our goal is to modulate the limbic system, the accumbens, without making a lesion, because we believe that this is modulation is just a better way to go than making a lesion, especially in an important structure such as the accumbens. And we also have a alcohol addiction trial going on. Again, the target is accumbens as well. And we have published, myself have published a couple papers on using responsive neurostimulation, or DBS, for alcohol addiction in the past. And we are very looking forward to working with a couple centers who are very interested in alcohol addiction studies in the near future. Now, all this is very cool, but why ZAP-X? I think Tim had a slide saying that, explaining why ZAP-X is superior in sparing healthy brain tissue. This is very important for brain mets treatments. I would say that this is even more important for radiomodulation concept, because we're talking about 5 gray, 10 gray, 12 gray, which we used to believe that this is so dose that doesn't really matter. It turns out that it actually matters, that dose as low as 5 gray actually has effect on neuronal activities. And ZAP-X seems to be the only system out there that's very good at controlling dose gradient. And why is that important? Because we're dealing with very small brain structures. For example, lateral habenula, which is indicated for depression, the volume is around 30 cubic millimeter. And we have the beta nucleus substratum analysis, which is indicated for OCD, and the mean volume is about around 0.06 or 27 cc. And then we have the CMPF, which is indicated for epilepsy, for Tourette syndrome, and for a mentally conscious state as well. And again, the volume is around less than 0.2 cc. So we're dealing with very, very small structures. And when you try to target these structures, you have to be very precise, because otherwise you're modulating neural circuits outside of your target area. And this is why, and we're not stopping we're not stopping here. To do that, we need both hardware and software. We need both the right hardware and the right software. We are now in the process of building an even smaller collimator, which is a 3 millimeter collimator. With that, we're able to deliver even smaller radiation beams to a specific target region indicated in a neuropsychiatric indication.
Hemmings, you have, please.
And yes, just a couple last slides. And with the new software, what we call the ZAP-X, we're improving the software planning systems too. For example, we're putting in the ACPC plane alignment as a function of the neurosurgeon. This is how we see the world. Everything is based on the ACPC plane. It's not in the previous planning software system, but now it is. So right now we're trying to rebuild the whole system around the functional realm. And there's this thing called dose sculpting, and you can see here in the video that basically you can see real-time changes in dose gradient. And we believe this is also very essential when you try to target very small structures, for example, SCG and the BNST and so on. And with that, I conclude my talk today, and would love to take any questions. Thank you.
Thank you, Hemmings. So while we're very proud of what the ZAP-X is today, for those of you who are unaware, we're actually on the cusp of doing even bigger things. So today, the ZAP-X is a point-and-shoot machine, but over the course of this year, we're going to be validating the new concept of dynamic spherical delivery, where you can, in a rotational way, deliver continuous arcs and create all kinds of weird patterns, from flying saucer to egg-shaped structures and oblique and anti-oblique spiral patterns. So yeah, what I'd like to say is the best is even getting better. So just stay tuned. So that's what we're capable of technologically. Today we talked a little bit about what that means in a real world of the clinic, especially those of you who are so experienced with gamma knife radiosurgery. Perhaps some of you now at a certain inflection point will choose to want to consider what ZAP-X might offer to you and your hospital. So thanks for listening, and we can now maybe have time for a question or two. Mark, I'm going to hand it over to you. You let us know how much time we have left to handle questions.
Sure.
So thank you everyone for attending.
Yeah, thank you. We have a few minutes, and I want to be respectful of everyone's time, but we did receive a question here, and this is the Mount Everest of all questions, one we constantly get, and I'll be interested in everybody's input. Seems that RadOncs and system administrators, they think TrueBeam is as good as Gamma Knife or ZAP-X for treating METs or benign lesions. Can you comment on this problem? Now, I want to add in another question, so we'll kill two birds with one stone. Someone else asked, does V5 really matter? So I think those two are related. I'll, John, do you want to start with that, or Shaber or
Well,
Tim?
well, I'm happy to cut to the quick. We showed in an article last year, not me, but the Miami Baptist and some other hospitals showed that when it came to treating multiple metastasis, you could do a much better job of sparing normal brain using a gamma knife-like approach or equivalent a ZAP-X approach, and is controlled as compared to my old CyberKnife, and even more so the Variant Edge. Yes, by the record, I am designated as the creator of Edge. Edge is very fast, very, very fast, and very efficient. The trouble is, it smears lots of lower dose radiation over the normal brain. We now know that that's injurious. So yes, Schmider may think it's equivalent. God bless him. Put his head under the Edge machine. But I suggest if you care about your brain or your patient's brain, you use an isocentric type technology. Could be the gamma knife, but as you can now see, we think the ZAP-X is the better solution. And does 5 gray matter? Look at the science, and you're going to see more and more come out. 5 gray is a threshold above which you will see change in brain circuit function. So stay abreast of the literature, and we'll be having further discussions and webinars about that very number to date in the future.
Super. Another question, perhaps for Dr. Chen or Dr. Danish. How much time does it take for treatment planning?
I'll take a shot of it. So this is a learning curve, and yes, the first 3 months takes a longer time. I would say between 2 to 4 hours for the physicist, the radiation oncology neurosurgeon to get it done. But now, if I tell you, like right before this conference, I have two brain mets. Literally took our physicist in 20 minutes to do the planning, and I able to sign a plan in an hour later. So to get everything done in one day, it's possible. Obviously, the complex plan may take a couple hours, but I don't think anything would take more than 3 hours for the physicists. They say if you 6 months, 9 months into the treatment planning, once you know the ins and out of it, taking 3 hours is considered a very long time.
Very good. So we're almost exactly on schedule here. I do have one question. By the way, other questions that we've received, we will follow up with you independently. But John, we're going to put you on the spot here. Perhaps not a question for a CEO, but are there incentive programs to transition from a Gamma Knife program to a ZAP-X?
We will make it worth your while. Just reach out to us and tell us if you're committed to coming over to the ZAP team. Not that we don't respect the gamma knife. We'll make it worth your while, and we'll make it worth your institutional while. And we'll put the ROPR incentive in front of you. Okay? That will not be a problem.
All right. I want to be respectful again of everyone's time. We thank everyone for joining us today, and we hope you found it productive. And a special thanks to Dr. Adler, Dr. Wu, Dr. Chen, and Dr. Danish for all of your wisdom today. Thank you.
Thank you, everybody. Thank you, Mark.
Thanks, everybody.
Thank you.
Thank you.
Thank you.